Hi, everyone. Hope everyone is having a great morning or afternoon, depending on where you are dialing in from. We are really excited to kick off our inaugural webinar series at Soul Mental Health with a topic that is really near and dear to my heart, which is treating substance use disorders in a primary care setting. I think we have our audience for today, so let's go ahead and kick off. Just a few housekeeping items. There is a question and answer feature in Zoom that you should see either on the right-hand side or using the top navigation bar. If you have a question that you want to ask during the presentation or afterwards, feel free to drop it in there. My team and I will be monitoring that over the course of the webinar, and I'll either pause as we go to take questions, and we'll certainly either answer all the questions at the end, or if we run out of time, we'll be sure to follow up afterwards with everyone to make sure that questions got answered. So with that, thanks again for joining us, and let's dive in. So I see some familiar names on the audience list, as well as some new ones. So before we dive into the agenda, I want to take a minute just to introduce myself and to introduce Soul Mental Health, or reintroduce Soul Mental Health. Yeah, very quickly, I'm Arpan Parikh. I'm a double board certified physician by training. I trained in both psychiatry and addiction medicine in New York City, and have been practicing both of those specialties, primarily taking care of patients who have both substance use disorders as well as co-occurring non-substance use psychiatric illnesses. I've been the chief medical officer at Soul Mental Health. We are building a next generation outpatient mental health platform. We exist to help individuals find healing and balance. We want to help bring every individual that we touch peace of mind, and we really exist to serve the mental health needs of our communities through an integrated approach. Very briefly, Soul Mental Health was born out of the vision of creating a comprehensive, meaning including both psychotherapy and psychiatry approach to addressing and treating the mental health needs of communities. We take a hybrid brick and mortar plus virtual approach so we can best meet the needs of our patients and our partners in our communities. And we've grown to cover a relatively wide geography in a short period of time. So today we have clinics and we see patients in Colorado, Texas, the DC metro area, and New York. We take a lot of pride in the partnerships that we create with our primary and specialty care colleagues in the communities that we're a part of. And we take a lot of pride as well in closely coordinating care with our external partners. So, after this, we'll be sure to follow with everyone in an email with some more information about Soul. We'll also include our contact information if you want to get in touch and think about what a partnership with your organization or your practice or group might look like. And we'll also be sure to include links to the CME credits, so you can be sure to claim those after we wrap up. So what's on our agenda today? 6 main topics. One, I want to talk about terminology. We're going to just talk very quickly about some advances and evolutions in the way we talk about substance use disorders, so that everyone is up to speed and can use the most sort of modern and patient-affirming language when we're talking about a relatively sensitive disease area. Number 2, we'll spend a few minutes on why this is an important and worthwhile topic to spend an hour of your morning or afternoon thinking about as you take a break from caring for patients. Number 3, we'll talk about a really useful framework to identify and screen patients who might be suffering from substance use disorders. Number 4, we'll actually go through a brief intervention that you as a primary or specialty care physician or clinician can execute in your office. So you can actually do it with the patient while you're sitting with them, less than 10 minutes, and actually get the ball rolling on addressing and treating a patient's substance use. Number 5, we'll spend a good chunk of time on the latest pharmacotherapy. In particular, there's one medication that is extraordinarily effective and very underutilized in the primary care setting when it comes to treating substance use disorder. So I want everyone to walk away from this feeling comfortable with that medication being naltrexone. And then finally, we'll follow up, like I mentioned, with resources in an email, including the CME credits, a PDF of this presentation, and then a way to contact us if you want to think about further collaboration or partnership. So diving into terminology, this is an area that is really important to me and one in which I have a lot of passion. There just tends to be a lot of confusion in the way that we as the medical establishment, we as clinicians, think about, conceptualize, and speak about substance use. And that's evolved over time. I want everyone who's listening in right now to be up to speed with the latest terminology so that when you're speaking to patients, when you're documenting in their charts, when you're collaborating with your peers, when you're referring them to higher levels of care, you can use the right and most technically accurate medical terminology to describe the symptoms or the diseases that your patients are suffering from. So the way our sort of subsector in healthcare has evolved over the last, call it 3 to 5 years, has been to move away from the more legacy and stigmatizing language that many of us trained hearing and using to more contemporary and patient-affirming language that is pervasive not only in the DSM-5, but also just in colloquial conversation among specialists. So we want to avoid a lot of the language that you see on the right-hand side of the screen. Terminology like substance abuse, polysubstance, substance user, addict, alcoholic. In place of those legacy and stigmatizing terms and language, today, we aim to use the terminology and types of phrases you see on the left side. So, we've replaced substance abuse with substance use. We've replaced substance abuse with substance use disorder. And that's how it's categorized in the DSM-5. And that is how the ICD-10 and 11 codes have been updated to reflect. We've also replaced substance user with substance misuse or misuser. And then finally, we try to avoid words like addict and alcoholic, and instead describe patients with the specific substance that they may be using or misusing. And finally, we think about dependence as being something that's physiologic. So, for a patient who is suffering from dependence, we want that to mean a very specific clinical situation, which is they are able to tolerate increasing amounts of a medication. And when we stop that medication or that substance, they experience withdrawal as being the true definition of dependence, and not conflating dependence necessarily with substance use or a substance use disorder. Why is all of this important? Why are we spending an hour talking about this? Why is this sort of at the height of cultural zeitgeist today? Why do we see news articles about substance use, about overdoses, about lack of access to substance use disorder treatment in America? These statistics, I have no doubt, are numbers that each of you feel in your offices every day as you take care of patients. The latest data we have suggests that more than 16% of the American population aged 12 and over had at least one substance use disorder in 2021. Let's just pause for a second and let that sink in. 16.5% is a massive number. That's nearly 1 in 5. So this is a disease process that impacts a tremendously large number of Americans. Of those 16.5% of Americans, only 6% receive treatment. So not only is this a very common disease, it's one that nearly no patients receive treatment for. Why is that? Nearly all Americans who didn't receive treatment at a specialty facility didn't think they needed treatment. So, part of the problem is lack of access to care. Folks who identify themselves as having a substance use disorder, or folks whose primary care doctors or specialists identify the SUD. But the vast majority of folks who don't get care actually don't get care because there hasn't even been identification of a need for care. And that's why I feel this talk is particularly important. For the primary care clinicians and groups and organizations who are tuning in, you truly are the first line of defense. You are who most Americans go to when they, need to work up a symptom that they're experiencing, when they need support, when something's not going right and they don't know quite what it is. So, equipping each of you with the tools and the vocabulary to talk about and start to address substance use is a key part of getting more Americans access to what is ultimately a very deadly disease process. And then the last statistic is a really impactful one as well. Almost 14% of all young adults, so we're saying age 18 to 25, had both a substance use disorder and a non-substance use psychiatric illness in the past year. That is a group of patients that I've spent my career taking care of. And it's really critical to understand when you're seeing a patient who has a psychiatric illness, odds are relatively decent that there may be either substance misuse or substance use that is comorbid. And we know from the data that the right approach is to treat both in parallel, because if we try to treat just the non-substance use disorder psychiatric illness or just the substance use disorder, it's actually really difficult to address the patient's overall health. So needless to say, each of you feels this in your practices, but just to put some numbers behind it to quantify just what the scope of substance use in America today is, and also what the severe lack of identification of substance use disorder and lack of ability for patients to engage in treatment. Of course, substance use disorder in and of itself is a dangerous and particularly deadly disease. Beyond that, we all know that substance use also directly leads to and causes and worsens medical comorbidities. Again, nothing on this screen is going to be very new to many of you, but I think it's really worth spending a couple of minutes in going through. Number one, we know the use of alcohol and or illicit substances both directly causes and complicates many chronic medical conditions. The very medical conditions many of you are a patient's primary treating clinician for: diabetes, CHF, end-stage renal disease. Those diseases become exponentially more difficult to manage when there is comorbid substance use in the picture that's not treated. Number two, we know that patients who are using IV substances have a greatly increased risk for infectious disease, including but not limited to hepatitis C and HIV. Number three, we know for patients whose substance of use is primarily alcohol have a dramatically increased risk of cancer, including oral and GI cancers in particular, and also are at higher risk for hepatic and endocrinologic complications. And then perhaps most importantly, we all know that the use of any substance may lead to a decreased or complete inability to care for ADLs. It dramatically impacts a patient's quality of life, also dramatically impacts a patient's ability to engage in care for their chronic medical conditions. So when we're thinking about overall patient health and wellness, an untreated or undertreated substance use disorder makes this comorbid medical conditions nearly impossible to treat, and to a T worsens outcomes. So what can you do about it? What can a primary care clinician, primary care office, specialty group do about its patients who may be suffering from substance use that's either identified or not? The great thing here is there's a really, effective, well borne out in the literature and relatively simple framework that we can use to tease out and then ultimately treat substance use. That framework, some of you may have heard of this before, is called SBIRT. That stands for screening, brief intervention, and then referral to treatment. This is an evidence-based framework, as I mentioned, supported by the Institute of Medicine. It's been effectively implemented in thousands of primary care and behavioral health settings across the country. When we look at the literature base for SBIRT, we see that following SBIRT implementation and then looking at a 6-month follow-up period, patients who had a completed SBIRT course demonstrate a 39% decrease in heavy alcohol use, and almost 70% decrease in any substance use. They're pretty dramatic numbers. And as we'll go through, and as you'll see, SBIRT is a relatively easy to implement framework that each of you can use in your practices. Before we get into SBIRT itself, I want to spend a couple of minutes just running through clinical interview pearls that I've picked up in my own practice and career. These are some of the most critical questions I ask my patients as I'm doing a comprehensive substance use history that not only help me quantify a patient's potential substance use disorder, but also help me think about the right treatment plan moving forward. Some of you may be utilizing some of these questions. I would encourage all of you to utilize all of these together as appropriate as you're taking care of patients who either have a known history of substance use or you have a suspicion of it and you want to tease it out. Number one, I'm sure most, if not all of you do this, but getting a thorough history of each substance use. So, asking patients one by one for each substance they report having tried or used in the past. When was the first time they used? When was the most recent time they used? What was their route of use? What was their peak use and when was it? Then for each substance, what was the period of longest sobriety? And not just the longest period of sobriety, but what helped them maintain that? Number three is maybe the most meaningful and impactful question out of these 8. And if you take nothing else from this slide, I would encourage all of you to ask all of your patients this when you're discussing either alcohol or substance use. Take a moment away from the somewhat kind of list-based, running through a checklist and ask patients why they use. I found that stepping back from just the structured interview and asking a patient, so tell me, what does alcohol, tell me, what does cocaine do for you? How do you feel when you use it? Why do you use it? The world of information that question opens a door into is invaluable. It opens a door into trauma. It opens a door into psychosocial stressors and challenges. It opens a door into so many of the underlying driving factors that often are either directly causing or indirectly worsening a patient's substance use, psychiatric disease, and also medical comorbidities. And more than that, it gives patients an opportunity to connect with you as a person. And it breaks a little bit of the clinical ice, so to speak. So give it a try the next time you're seeing a patient and talking about substance use and getting a history and see how it goes. Then kind of going back to the structure, one thing that's critically important when we're talking about teasing apart substance use disorders from psychiatric comorbidities is, was the psychiatric comorbidity present when substances were not being used? We all know that the use of substances and the use of alcohol itself can cause symptoms that could look like psychiatric illnesses. We also know that withdrawal from alcohol and withdrawal from substances can look like psychiatric illnesses. So to give very concrete examples, a patient who is drinking a lot of alcohol could suffer from a depressed mood, but the depressed mood could actually be an alcohol-induced depressive disorder. A patient who's using LSD may experience hallucinations. But that may not be representative of a psychotic illness or schizophrenia. That may be a hallucinogen-induced psychosis. Similarly, patients who are withdrawing from substances may look like they are suffering from acute psychiatric symptoms while it's actually a result of the acute withdrawal syndrome. So as we're getting histories of patients' psychiatric symptoms and their substance use, try to think about it in your mind as a chronology, and then teasing out when exactly were the psychiatric symptoms present, when exactly was the substance use present, and then are they overlapping or not? And that can be really useful in creating an understanding of, are the patient's symptoms from an organic psychiatric illness, or are the patient's symptoms secondary to either substance use or acute or chronic withdrawal from substances. Then shifting to the second row here, these questions do a great job at helping to understand the patient's risk profile and then developing a treatment plan. So, really important to ask about treatment history. So what types of formal treatment has a patient received in the past? How long were they engaged with it? And what was the outcome? Did it actually help or not? Has a patient been in acute inpatient or emergency detox? Have they engaged in inpatient or residential rehab? Can help you get a sense of the severity of their symptoms and also their ability and willingness to engage in treatment. Really important to ask about medication history. So have they been prescribed MAT before? Whether that's disulfiram or naltrexone or buprenorphine. And then, of course, also asking about the outcome. And then finally, as you're thinking about risk profiles and who's safe to take care of in a primary care setting versus who might need to go to a specialty or inpatient setting, asking about complications. Has a patient experienced seizures or have a history of seizure disorder? Do they have a history of delirium tremens? Have they required admission to an ICU for stabilization as a result of their substance use? So taken together, these questions can provide a very comprehensive perspective of patient substance use. And again, I'll really double down on that third tile in the top row. If there's just one takeaway here, ask your patient, your next patient, who you're talking about substance use with, what it does for them. And I think you'll be surprised by the conversation that leads to and the insights it gives you as you think about connecting with the patient and also then developing a treatment plan. So switching gears back to SBIRT and how can you implement or operationalize this evidence-based framework into your practice? Step one is screening. So we want to think about an effective tool that is relatively sensitive and specific in helping us to tease out patients who might be either at risk for a substance use disorder or meeting criteria actively for substance use disorder. In my experience, having built and operationalized models in a risk-bearing primary care practice that eventually scaled across multiple states, the audit C+2, which is the scale that you see here on the screen, is maybe the most effective, the quickest to implement, and the least burdensome to patients. There are some longer scales out there. The DAST, D-A-S-T, is one that comes to mind, but it's almost double the length. And, patients certainly at some point hit questionnaire fatigue, when we're hitting them with all sorts of standardized clinical metrics, both from a psychiatric perspective and a medical perspective. So if you're looking for a great screener to use in your practice, my vote is for the audit C+2, which you see here. And what the audit C+2 does is three things. Number one, it screens for alcohol use disorder. Those are the first three questions that you see. And that's the audit C scale. So how often did you have a drink with alcohol? How many drinks containing alcohol do you have on a typical day? And then how often do you have 5 or more on one occasion? And the time scale is in the past 3 months. The +2 part of the audit C+2 are 2 additional questions that have been added that tease out cannabis use and then tease out all other substances. So you see question 4 is how often have you used marijuana? And then question 5 is how often have you used an illegal drug or prescription for non-medical reasons? So taken together, these 5 questions are really effective at screening in patients who might be at risk for substance use disorder or already meeting the criteria. So let's say you take this to heart, you implement the audit C+2 into your practice, you ask it to every new patient who's coming in the front door for a primary care visit, what do you do with the data once a patient fills it out? It's a relatively simple scale to score. So there are 3 possible results. We think about negative, positive, and high positive. For a negative screener, that is either less than 3 points for women or less than 4 points for men on the first 3 questions, which is the audit C, either a 0 or a 1 on the cannabis question, and then a 0 on the other drug question. So those are patients for whom you could and should feel relatively comfortable not necessarily having to spend a lot of time diving into further questions around substance use. Then we have folks who screen as positive. So these are folks who, for women, score either 3 to 6, or men score 4 to 6 on those first 3 questions, or score 2 to 3 on the cannabis question. These are folks who are at risk or high risk for developing substance use disorder. And we'll talk about the next steps for that cohort of patients in the next slide. And then the highest category are high positive patients. So these are folks who score either a 7 or higher on the first 3 questions, a 4 on the cannabis question, or any positive response to the last question. And again, we'll talk about the 5 types of interventions you can use for high positive patients a little bit later in the presentation. But let's focus in on that second category, because in a primary care or non-psychiatric specialty care setting, the majority of patients you see are probably going to fall into that second bucket if they're suffering from substance use disorder or at risk for SCD. So you implement the audit C+2, patient comes in and completes it, and they score in the positive range. What do we do now? The data would suggest using a tool called a brief negotiated interview, or BNI. This is a tool that's out of the BU School of Public Health in Boston. It's designed as a primary care intervention. So, you all are very busy and take care of many, many patients in the course of a day, a week, a month, and a year. This is just 5 or 7 minutes and can be very meaningful in helping to build rapport with the patient and also then start to develop an action plan. Specifically, the BNI has a 5-step model. Step 1 is building rapport with the patient. Step 2 is engaging with the patient on the potential pros and cons of their alcohol or substance use. Step 3 is providing information, eliciting information, and providing the patient feedback. Step 4 is a readiness ruler. If any of you are familiar with motivational interviewing or motivational enhancement treatment, readiness ruler sort of comes from that school of thought. And then the last step, step 5, is developing an action plan. What does the BNI actually look like? This may appear relatively small on your screens. This will be in the materials that we send out at the end. So you'll have this in your inbox and you can, print out the PDF and use it with your patients. But, you can see at a high level, building rapport is relatively simple. I'm sure everyone here is fantastic at building rapport with patients, but you can see that the second sentence it's that question I encourage you all to think about. Where does your current substance use fit into your life? What does it do for you? Such a powerful way for us to build rapport with our patients. Step 2 is thinking about the pros and cons. So again, questioning the patient about what are some of the good things about using the substance, and then having them think about what some of the drawbacks or what the negatives that they experience in their life might be. Number 3, as we discussed, is sort of eliciting information and then providing feedback. So asking more questions about substance use, their substance use, and then providing them with information about what some of the either social or medical complications could be. Step 4, readiness ruler, is actually asking patients on a scale from 1 to 10 or 0 to 10, how ready for change they are. And then using that information to probe at what it might take for a patient to move further along and closer to the ready to make a change side of it. And then step 5, and the last one, is an action plan. And, the Boston University framework has essentially 3 components here. So number 1 is identifying strengths and supports that patients can utilize as they think about addressing their substance use. Number 2 is really powerful, is just writing down the steps. So not just having a discussion, but actually either you as the primary care clinician or the patient themselves documenting it on pen and paper, or, in the note that goes with the patient handout that a patient gets after the visit. And then number 3, offering the patient the appropriate resources, whether they are in your own clinic, whether they're MAT that you could provide, whether it's referral to community resources or specialty resources. And then finally, thanking the patient. So This is a relatively simple framework, 5 minutes, maybe 10 minutes max, that you can start to utilize for those patients whose screen is positive on the Odyssey +2. We'll send this out. Okay, so that's for a patient whose screen is positive, but what do we do for patients whose screen is high positive? For that group of patients who are at the highest risk for developing, or in many cases may already meet the criteria for a substance use disorder, we think about 5 types of interventions that you can utilize or engage for a patient in the primary care setting. Number 1 is medication management, and we're going to spend some time on that on the next slide. Number 2 is individual psychotherapy. So if you have in-house psychotherapy capacity or capability, or you have a great partner in the community, perhaps you operate a market or a city where Seoul is, getting a patient over to a psychotherapist can be a really powerful intervention for patients who are at risk of or suffering from SUD. Number 3 are the peer support models that many of us, hear about and know about. There are programs like AA and NA that are more faith-based, and then there are sort of non-faith-based corollaries. The probably most prominent one being SMART recovery. Number 4 is group psychotherapy. Again, you may offer that in your clinics. You may have partners in the community who offer that. It can be very powerful with SUD. And then finally, self-management. So, we always have to consider a patient's readiness. And for patients who are not ready to take a step that is medication or formal treatment, you may be the holding environment. So agreeing with a patient to have ongoing monitoring of their substance use. Maybe you see them a little bit more frequently for their routine, physical health check-ins, and you provide them with support so that when they do become ready, we can pounce on that opportunity to engage them in the right type of care. So how do we think about using medication to treat substance use? There are a few medications that have been FDA approved to treat 2 substance use disorders, alcohol use and opioid use. For alcohol use, or AUD on the left side, you see really 3 main medications. We have acamprosate, also known as Campril, disulfiram, also known as Antabuse, and then naltrexone. On the OUD side, on the right side, we have, again, naltrexone, but also buprenorphine, also known as Suboxone, naloxone, which, as many of you know, is used for acute opioid intoxication or overdose, and then methadone. For the purposes of this audience, I want to focus in on one of these medications, which is naltrexone. And there's a few reasons why. So, naltrexone is very efficacious in treating both alcohol and opioid use disorder, number 1. Number 2, it is not a controlled substance and doesn't require any additional registration or kind of regulatory oversight the way methadone or buprenorphine do. So there's almost no barrier to prescribing it in an outpatient primary care or specialty care setting. And number 3, it's a very well-tolerated medication for treating AUD and OUD. So, specifically thinking about AUD as probably the most common substance use disorder that many of you encounter in your primary care practices, we want to think about naltrexone as really the first-line treatment. It has multiple routes of administration. It's just once a day and is very well tolerated. Antabuse and Campril, certainly can be considered based on the clinical presentation, but I can tell you based on literature and based on my experience, they're generally not as well tolerated, nor are they as efficacious as naltrexone can be. So how does naltrexone work? So we know that the psychoactive effect of alcohol, and for opioids, for that matter, are induced through dopamine release in the central rewards pathway. The nucleus accumbens probably being, one of the most important structures in that pathway. Naltrexone is a mu opioid receptor antagonist. So just to pick that apart, it is specifically targeted towards opioid receptors. There are multiple types of opioid receptors. Naltrexone targets the mu variety, and it's an antagonist. So it has a very high affinity for the mu opioid receptor. So it finds those receptors, latches onto them very tightly, and then blocks their activation by other opioids. So by blocking the mu opioid receptors and kicking off whatever was occupying those receptors previously, naltrexone can reduce cravings for alcohol, and it also reduces the centrally reinforcing effects of alcohol. So not only do patients, feel less of a need to drink, if they do happen to drink, which they can do without, feeling violently ill, it just doesn't feel as enjoyable. And over time, that then reduces that reinforcing, central need to drink. Just a few pharmacodynamics around naltrexone. It is absorbed in the GI tract, and it's hepatically metabolized when it's taken in its oral form into the active compound. That is important because, as we'll talk about, you have to think about using naltrexone in patients who have any hepatic insufficiency. The fourth bullet is the one I want to really triple down on, because there's so many misunderstandings about naltrexone. Number one, naltrexone is not a controlled substance. Number two, naltrexone requires no special licensing to prescribe. Number three, naltrexone carries no risk of dependence, tolerance, or misuse. So not only is naltrexone a very effective medication, it also has very few risks. And given this profile, I think it's quite sad how underutilized it is, not only in the primary care and specialty care setting, but even in the psychiatric setting. So anything I can do and that we can do, to get the word out and help folks learn about naltrexone and use it is a net positive for our current patients and future patients who might be suffering from either alcohol or opiate use. There are a few things to think about when using naltrexone. Like I mentioned, when taken orally, it is metabolized in the liver. For that reason, there is a black box warning for patients in that naltrexone can cause or can worsen hepatocellular injury. General best practices is getting at least one baseline LFT before starting naltrexone. My general guidelines, and you should take these and adopt them to your practice and comfort level, is if the LFTs are under 3 times the upper limit of normal, I generally am okay proceeding myself, as a non-primary care clinician. If LFTs are 3 to 5x, I'm a little bit weary or hesitant, but generally end up proceeding with caution. And then if the LFTs are over 5x, I normally consult GI. You may consider that to be within your comfort level, or you may consider consulting GI as well. What I can tell you, though, is 95 times out of 100, when I was caring for a patient who had severe liver disease before I started naltrexone, and I consulted either with their or with a hepatologist, the response that I got was, whatever you can do to curb or stop this patient's alcohol use, we will support. Because their liver disease is almost completely driven by their alcohol use. And if they don't stop drinking, not only will their liver completely fail, but they will die. So, when we think about the risk-benefit consideration of a medication like naltrexone in patients who have severe hepatic injury at baseline, let's just make sure we keep in mind the fact that in many or most or all of these cases, that hepatic injury is being caused by the condition we're going to treat. So generally speaking, again, it's different for each patient, and you should make a informed decision. Generally speaking, that risk is worth taking because we're going to potentially, put the disease in remission that's actually driving the liver disease. One other interesting consideration is naltrexone comes in an injectable form, a long-acting injectable that goes by the brand name of Vivitrol, given once monthly, given as an IM. And because of its IM route of administration, it actually bypasses the hepatic first pass. So if there's a patient who has some, esoteric hepatic pathology that makes GI uncomfortable with naltrexone, oftentimes the way to get around that is to use the long-acting injectable IM, because that actually totally bypasses the liver, and we avoid all of the potential hepatic injury that comes with naltrexone. And then secondly, we have to be really careful initiating naltrexone if a patient has any opioid, whether that's prescribed, like Percocet or Vicodin, or illicit, like heroin, in their system. The reason why, like I mentioned earlier, naltrexone has a really high affinity for the opioid receptor. So if a patient has Percocet or heroin in their system that's occupying those opioid receptors, the naltrexone is going to go in there, it's going to find it, and then rip all of those opioids off. And that will result in a very uncomfortable situation for the patient. Now, it's not medically dangerous. So, acute opioid withdrawal, however uncomfortable it is not clinically dangerous and does not lead to morbidity or mortality the way acute alcohol or benzo withdrawal does, but it may make a patient hesitant to re-engage with you. So we want to avoid that. Generally speaking, my practice is documentation that there hasn't been any use of prescription or illicit opioids for at least 7 days. Again, it's always about weighing the risks and the benefits. If it's been 2 or 3 days, and the alcohol is really problematic, then maybe you make that decision in conjunction with the patient to go ahead and try it. But with them knowing that they may experience some acute withdrawal because we're going to precipitate that out of their system. And then as you think about using naltrexone in your practice, always important to talk about side effects with patients and also be aware of them yourself. So the most common side effects that I see and that we see in the literature with naltrexone are GI symptoms like nausea and vomiting. You see headaches, might see dizziness and orthostasis. You may see fatigue and somnolence and a little bit of anxiety. Less common side effects are just GI distress, like upset stomach, rash. You may see changes in appetite, either up or down, changes in mood, depression, and then a decrease in libido. A few special populations to think about with naltrexone. If you're prescribing patient naltrexone and they're going to have scheduled surgery, a patient should generally stop naltrexone 72 hours prior, just so that they're not complicating the post-op pain management protocols that surgeon or anesthesiologist might be prescribing. Secondly, if a patient has unexpected acute pain, patients should be counseled on, and they should be telling their specialists about their naltrexone use so that, they can use medications that will get around the blockade. So, generally we think about high dose NSAIDs, we think about regional anesthesia, or we think about very, very high dose opioids while a patient is on monitoring, as ways to give patients acute pain relief while naltrexone is still in their system. And then finally, in patients who are pregnant, again, this is a very personal risk-benefit calculation to be made with the patient, and should always be made in conjunction with the patient's OB. That being said, the literature, the evidence, and the data for naltrexone is similar to that of other psychiatric medications, which is that the risk of untreated substance use disorder, i.e. untreated alcohol use disorder or untreated opioid use disorder, generally speaking, is significantly higher than the potential risk of naltrexone on the developing fetus. So, odds are that risk-benefit analysis is going to come down the side of it's worth taking the risk of naltrexone to a developing fetus if it means that it keeps the patient's mother clean/sober. So let's touch on naloxone for just 30 seconds, since it's an important tool in the toolbox as well. Naloxone is a mu-opioid antagonist, similar to naltrexone, that's approved to treat acute opioid overdoses. So if you have a patient who's in treatment for OUD, or is at risk for OUD, or has a family member or loved one who has OUD, I would highly recommend all of you to prescribe those patients naloxone. There's basically no downside to anyone carrying naloxone on them or having it in their car or having it in their home if either they or someone they're close to suffers from opioid use disorder. All 50 states have provisions for providing naloxone to patients. Any clinician can write it. You don't have to be a psychiatrist. You don't have to be an addiction medicine doctor. And my recommendation is you write the patient for 2 units, just because, with the really high potency opioids that are circulating in the market today, sometimes 1 dose of naloxone isn't enough to reverse an acute overdose or intoxication. So having a second unit is really important and can be life-saving. So as we come to the home stretch and think about a recap here, the 5 takeaways I have are: number 1, SBIRT is a validated and relatively simple framework that each of you can utilize in discussing a patient's substance use in your primary care or specialty care setting. And number 2, substance use disorders profoundly impact the physical health of Americans. And your primary care clinicians and specialty care clinicians are the first line of defense for almost all Americans. Number 3, as we just went through, naltrexone is a very effective, very safe, and generally very underutilized tool in our SUD toolbox. Number 4, beyond naltrexone, we have multiple FDA-approved medications to treat alcohol and substance use disorders, specifically opioid use. And then most importantly, number 5, initiating treatment in the primary care setting can greatly accelerate the path to recovery and optimize a patient's odds of not only reaching their goals, but also optimizing their physical health comorbidities. So thank you all for tuning in and joining us for this inaugural webinar in what will be a regular and recurring series. Our next topic is going to be advanced psychopharmacology for the primary care clinician. So we're going to have one of our psychiatrists present on some more advanced techniques and tricks that you can use as a primary care clinician to address your patient's psychiatric symptoms. For today's session, we're really pleased to offer 1 AMA Category 1 CME credit. A half of the credit will come from an activity around SBIRT, and then a half credit will come from an activity around MAT. So in the email that we'll send out to everyone who attended afterwards, you'll see 2 separate links. Please click each one, and then completing the activity will give you a half CME each, so 1 in total. And as I mentioned, we will also include in the follow-up email our information as well as more information about Soul. As a comprehensive outpatient mental health platform, we'd love to partner with you to be a resource for you and your clinicians as you have patients in your communities who are suffering from any psychiatric symptoms or diseases. So I will end here. You'll see my email on the screen. You're also welcome to email me directly if you have any questions or thoughts or want to follow up on something either about this presentation or about Soul. And then I'm also happy to take any questions. So if anyone has a question, I'll stay on for the next 5 minutes or so and can answer them. Feel free to throw them into the Q&A box. Thanks, all. So there's one question about how to recognize benzodiazepine abuse or misuse in patients for whom we're prescribing these medications. Fantastic question. I would utilize some of the same resources, frameworks, I should say, around identifying and screening patients. If you start to think about your prescribing a benzo for a patient and the dose is escalating, or it's becoming less effective, right? So now we see that a patient is developing a physiological tolerance, and perhaps they're developing physiological dependence, and they're starting to experience withdrawal if you try to taper or if they skip a dose. And then you see some, disordered behaviors around the benzo use. So they're, maybe not being honest with you about how much they're taking. You see that they're seeking it from other sources. That's when I think about misuse of a medication sort of bleeding into this area of substance use disorder. In this case, it's a sedative hypnotic use disorder. That all being said, I think it's also just worth thinking about what are we addressing or treating with the chronic benzo use in the first place. In my experience and in my clinical opinion, benzodiazepines can be really useful as short-term treatments. I think the literature is pretty convincing that they're not as effective long-term, and they're certainly not effective disease-modifying agents, right? They're more sort of symptom band-aids. So I think starting the conversation with the patient there can be a helpful framework or strategy, and then kind of following up with the patient and understanding their resistance, if they're resistant to coming off the benzo, and then whether that's again a result of physiological dependence and tolerance or the result of potential misuse or a use disorder. Happy to follow up offline. Feel free to send me an email on that. There's one question about finding out about support resources. We're going to include a bunch of the support resources, including our own information, in our follow-up email, as well as some community and national organizations that you can engage and that patients and their loved ones can engage when thinking about treating substance use. Question from Julia on how to prescribe naltrexone and how long should patients stay on it. Great question. It's really easy. The starting dose is the maintenance dose. There's only one dose. It's 50 milligrams. Comes in a 50 milligram tablet. It's once a day. That's it. For patients who are exquisitely sensitive and they have side effects they can't tolerate, sometimes I'll cut it in half and have them take 25 milligrams a day for the first 1 to 2 weeks, and then titrate back up to 50 milligrams a day. But it's just that 50 milligrams PO daily to start, and then onwards. In terms of how long patients should stay on it, I think about medication for treating substance use as one piece of the treatment. Generally speaking, there's other psychosocial factors that are impacting a patient's either need or want to use. So in addition to the medication, hopefully there's also in parallel processes in place that are helping to shore up or resolve those psychosocial stressors. Hopefully the patient's also engaging in psychotherapy, individual or group, or peer resources like AA or NA or Smart Recovery. If a patient's doing all those things over time, they'll develop the resilience and tools to maybe not need the medication anymore. I generally have a guideline of 6 months. So generally, if I start a patient on naltrexone, it's going to be for at least a 6-month period of time, while we give all those other pieces time to play out. And then once we reach that point, if a patient feels like they've made progress and feel ready to potentially taper off, then we give it a try and see if there are other kind of resilience factors, the other psychosocial pieces have improved to the point that they feel that they're able to remain sober without the medication on board. That being said, nothing wrong with taking naltrexone indefinitely. I've had patients who have taken naltrexone for decades, the same way they may be taking an ACE inhibitor or a beta blocker. And at least to the extent that the literature shows, there are not significant long-term complications, and certainly the benefits outweigh the risks in terms of the risk of relapsing on either alcohol or opioid versus the long-term risk of using naltrexone. Chloe has a question on what age to introduce the screening tool. Great question. Can follow up with some more information on this offline. Generally, I recommend starting as young as possible, as young as you see in your population. Certainly adolescents, as you saw in the data I presented, substance use disorder is a real thing that starts around age 12 or 13. And if you look at the statistics for ages 12 to 18, there is a pretty good chunk of adolescents in America who experiment with or regularly use substances. So it does require sometimes a slightly different approach. There are sometimes standardized scales and questionnaires that are geared towards pediatric adolescent populations. But I don't think there is really any downside to starting these conversations earlier so we can identify the potential disease process sooner and then get patients plugged into the right treatment. And that way they have the highest odds of achieving remission, which is our goal in all these cases. Great. That takes us right to the top of the hour, noon if you're on the West Coast, 3 o'clock on the East Coast, or somewhere in between. Thanks again for joining us. We're really excited to get this going and then to do this on a regular basis on topics that we've heard from our partners in the community are really important and of interest to them. So stay tuned for the next one, and we'll follow up in the next few days here with more information about the topic we covered today. Thanks so much, everyone. Have a good one.